Good
Yes,
morning.
Ms Fraser-Button.
Good morning, sir. This morning I'll be addressing matters around the Yorkshire Regional Transfusion Centre. The inquiries had the benefit of statements from Dr Flanagan, and prior to her death, Dr Angela Robinson provided a personal statement and a statement as part of the response from the NHSBT. Just for the purposes of the transcript, the relevant reference numbers for those statements are WITN 6933001 in relation to Dr Flanagan, and WITN 6926001 and WITN 6926003 in relation to Dr Robinson. The Yorkshire Regional Transfusion Centre was established in 1944 and was based in Leeds. If we could have NYOR 5043, please. This is the Yorkshire Blood Transfusion Service Annual Report of 1988-89, and if we turn to page 3, we can see the geographical remit of the centre. Unfortunately, on this version, it's not entirely clear, but at the top left corner, there's a list of regions, and if I just read them out, it's Airedale, Bradford, Calderdale, Dewsbury, East Yorkshire, Grimsby, Harrogate, Huddersfield, Hull, Leeds Eastern, Leeds Western, Northallerton, Pontefract, Scarborough, Scunthorpe, Wakefield and York, and that it gives the indication of the coverage of the centre. In terms of the work of the centre, again, if we can turn to NHBT 306233, please. And we pick up on page 3. What we have here is a Medicines Inspectorate report from June and July 1988, and we can see the introduction. The Yorkshire RTC in Leeds is located in the grounds of Seacroft Hospital. Part of the centre is a new building, opened in 1986, phase 1, and a new donor centre opened in June 1988. The centre hasn't previously been formally inspected. The population served is 3.2 million, taking in 24 hospitals, including 2 private hospitals. The centre employs approximately 350 staff in total and collects around 150,000 donations annually. At this time, if we go down to part 3, the senior staff list, we can see that Dr Tovey is the medical director and Dr Angela Robinson is listed there as the assistant general manager. And in terms of the products, we have whole blood, platelet concentrates, cryoprecipitates, fresh frozen plasma, 5-litre plasma pools, SAG-M red cells, concentrated red cells, filtered red cells, dextrans sedimented red cells and saline washed frozen red cells. And if we can carry on down to the bottom of the page, we see this from the inspector. Visits were made to 2 donor sessions, a static session in the centre and a mobile session in Cleckheaton. The procedures are basically the same for both and will change when the full computerisation programme is completed, scheduled for September 1988. And if we go over the page, the donor centre in the RTC is equipped with 6 plasma beds, so hemanytics, ultra-light portable machines, and 2 bleed beds. Then if we carry on to page 7, under the heading of microbiology, we can see that testing for hepatitis B surface antigen was being carried out, as well as HIV antibody and syphilis. And then selected donations are also screened for tetanus antibody, CMV antibody, and hepatitis B surface antibody. If we then look at the third paragraph in this section, we can see an explanation of how the microbiology testing is completed, and there is also this reference. As each tube is sampled, it's moved into a second rack. It's been put into a microtiter plate. The microtiter plates are supposed to be labelled with the date and the number of the first sample on the plate, as after they've been sub-sampled, these plates are frozen and constitute the microbiology stored samples. They're kept for 2 years. In fact, several plates only carry the date. So it would appear that some degree of stored sampling was being carried out at the Yorkshire Centre, albeit only being kept for 2 years in 1988. In relation to, sorry, sir. If we can then turn on to page 9. Under the heading Future Planned Changes / Developments, we can see that the major imminent development is the complete computerisation of the system, right through from donor records to product issue. This system's been running successfully for some years at the Welsh Regional Transfusion Centre in Cardiff, and the Yorkshire system has been installed in close collaboration with their Cardiff colleagues. It's planned to go live in September 1988. That's a whole series of points, sir, that we'll pick up through the presentation, but since we were on this document in relation to the staffing and population coverage, it made sense just to complete that document. If we move on in time to 1991, 1992, we can see how things have progressed, particularly in relation to facilities. Could we have NHBT 20097056_002, please? We can see that this is the business plan for 1991-1992. And if we turn the page, we see that by then the director / general manager is Dr. Angela Robinson and the deputy director is Dr. Flanagan. Could we then turn on to page 4, please? We have the overview, and then towards the middle of the page, the heading Customers. And it's noted that the Yorkshire service serves 3 distinct groups rather than district groups of customers. 161,000 donors, 5.1% of the eligible members of the general public of Yorkshire who are voluntarily donating their blood or plasma are entitled to receive quality service, care and attention in all their contact with the BTS. Of course, for our purposes, the information there about the numbers of donors is useful to note. Hospitals, by this time it's 27 NHS and private hospitals within the Yorkshire Health region are supplied with blood, and approximately 23 products or constituents of blood valued at £7.1 million. And then under the heading Bioproducts Laboratory, plasma to a value of £1.8 million in 1990-1991 is supplied to BPL as the source material for processing. And if we turn the page, under the heading Organisation, the Yorkshire BTS is headquartered in a recently extended and renovated facility within the grounds of Seacroft Hospital, Leeds. All medical screening and processing functions are carried out on this site, together with donor services, publicity and business services. From this base, 6 mobile teams, plus a 7th team based from an office in Hull, operates 6 days per week, visiting about 250 venues throughout Yorkshire. Additionally, 3 plasma/whole blood donor suites are located in the HQ, Leeds and Bradford town centres, and a unique clinical therapeutic service is provided from a ward within Seacroft Hospital. So we see there a growth in the number of plasma suites available within the Yorkshire region. If we move on to February 1992, NHBT 001 7246, please, Sally. We pick up a medical audit visit of the centre, and again we see those involved, Dr. Angela Robinson as the medical director and Dr. Flanagan as the deputy medical director. First of all, if we go to point 1.2 at the bottom of this page, we can see the work that the centre was doing in relation to its relationships with the hospitals in its region. 2 hospital transfusion committees have been established amongst the 14 hospitals served. These are at the largest hospitals served by the centre, accounting for approximately 30% of its services. They meet 3 monthly, and the consultant haematologist from the centre is invited to all meetings. Indeed, it was a feeling at the centre that consultant RTC medical staff should play an enabling role in the establishment of such committees.
Just pausing there. This is now 14 hospitals served, which compared with 27 and 24.
Indeed.
What area is this covering? What is it an audit of? Can we just go back up to the top?
We can see that at the top it's an audit of the Yorkshire RTC, so it's a little bit unclear why it's only 14 rather than the 27.
Yes.
The numbers aren't something we've been able to track through. It may be given it's the early 90s, so it may be that it's the combination of hospitals becoming bigger trusts, but we would need to check exactly what was happening in Yorkshire to be able to say that was the situation.
Yes. I mean, that seems the likeliest explanation, but we simply don't know, really.
We simply don't know, no. The important point I wanted to highlight from this document, sir, was the interaction that we see in Yorkshire between the RTC and the hospitals that it was serving.
Yes.
If we just carry on where we were, the committee at one hospital is multidisciplinary, and meetings were thought to be helpful. The other committee is about to hold its inaugural meeting along the same principles. The agenda for the established committee has primarily addressed terms of reference, and over the page, that's jumped a page, and maximal order blood schedules for surgical procedures. The audit of BTS activities has been included in the terms of reference. And then we read this about the Regional Transfusion Committee. The Regional Director of Public Health has been approached about establishing a Regional Transfusion Committee, but he does not feel such a committee is necessary, and that audit of the transfusion service is more appropriately undertaken at hospital level through their current audit committees or through hospital transfusion committees. 2 meetings a year are held with haemophilia directors, haematologists in charge of blood banks, and scientists. That picks up the question of the interaction with the hospitals, and if we carry on to page 4 of this document, under the heading apheresis activities, we can see at this time in February 1992 there were 4 apheresis clinics, 1 in Leeds, 1 in Bradford. And in terms of the work of the staff, if we could turn the page to page 5, please. We see the heading Donor Counselling. One associate specialist has overall responsibility for the counselling of donors positive in HIV antibody testing. This is arranged at a local hospital. Together with the consultant haematologist, she's also responsible for the counselling of donors found positive for markers of hepatitis C, who are then referred to a liver specialist. Donors positive for hepatitis B surface antigen are counselled by the Deputy Director, who also arranges to counsel plasma donors who have persistently elevated above 100 ALT values. Only consultant medical staff and the associate specialists counsel donors. Look-back programmes would be carried out for past HIV-positive donations as necessary by the Deputy Director via the consultant haematologist in charge of the blood bank in the appropriate hospital. They are the sort of overview documents that we needed to pick up in relation to Yorkshire. If we can then look at some of the more detailed points that arise. As we've seen, the senior staff at the Yorkshire Centre, the regional transfusion director was Dr. Derek Tovey. He was the director between 1966 and 1988. Dr. Tovey was succeeded by Dr. Angela Robinson, who held the post until 1994. Dr. Robinson was appointed a senior registrar in clinical haematology and blood transfusion at the Yorkshire Centre in 1971. She became a consultant in clinical haematology and blood transfusion in 1976. And this was a joint post with the Seacroft Hospital in Leeds. In the inspectorate report we saw a moment ago, she was described as the Assistant General Manager of the centre. In 1988, she was appointed... she took over from Dr. Tovey in 1988 and was then appointed Chief Executive and Director of the centre. Between 1976 and 1992, she was also an honorary consultant haematologist at the Seacroft Hospital. And between 1987 and 1994, she was an honorary senior clinical lecturer at the Department of Medicine at Leeds General Infirmary and St James University Hospital. On the 1st of May 1994, Dr. Robinson was appointed the Medical Director of the NBA, succeeding Dr. Gunson, and that was a post she held until 2007. Dr. Robinson was a member of a wide number of committees and working groups, including whilst she was a director of at Yorkshire, she was chair of the Northern Division meetings, and consequently from the 14th of August 1990, she was a co-opted member of the Medical and Scientific Committee of the SNBTS. She was a member of the Ad Hoc Working Party on Hepatitis C Look-Back, the NBTS National Management Committee from 1990 to 1992, and the NBTS BPL Liaison Committee between 1990 and 1992. She was obviously involved in very many other committees and working groups, particularly once she became Medical Director of the NBA, but they are the important groups whilst she was at Yorkshire. The third staff member to note is Dr. Peter Flanagan. He took up a post as consultant haematologist at the Yorkshire Centre in October 1989, with half his time being spent as a laboratory haematologist at Seacroft Hospital. He was then promoted to Deputy Director in January 1992, which was a full-time post, and he became Clinical Director in April 1993. On the reorganisation of the blood service into 3 administrative zones under the NBA, he was appointed Clinical Director of the Northern Zone in February 1995, based in the Leeds Blood Centre. Turning now to the question of funding and the relationship of the centre with the health authority. Until 1995, the Yorkshire Centre was part of and funded by the Yorkshire Regional Health Authority. Dr. Robinson's personal statement made clear that the Yorkshire Centre was initially funded by a lump sum payment made by the Health Authority to cover all of its costs. BPL didn't during that period make payments for the plasma provided to it, but as the inquiries heard previously, returned Factor 8 on a pro rata basis. Dr. Robinson's view of that was it worked well for the Yorkshire Centre as the volume of both recovered and apheresis plasma sent to BPL meant that the pro rata return of plasma products, for example Factor 8 and human albumin solution, was sufficient to meet the region's requirements. While initially all of the centre's funding was received from the Regional Health Authority, that changed to some extent when cross-charging was introduced in 1989 and BPL began to pay centres for the plasma they supplied. Dr. Flanagan has indicated in his statement that this changed further in 1990-1991 when the Yorkshire Regional Health Authority devolved funding for regional services to hospitals in the region. Initially, that devolved funding only covered the purchase of blood and blood products from the centre, but it was subsequently expanded to all products and services. In relation to cross-charging or cross-accounting, which was implemented in April 1991, Dr. Robinson's statement has explained it in this way. The Yorkshire Regional Health Authority devolved the transfusion centre's total budget and apportioned it to the individual hospitals, who then had to buy blood and blood components back from the centre. This meant that we had to come up with a unit price for whole blood, FFP, cryoprecipitate and platelets. The Regional Health Authority kept a central budget for specific services, particularly in relation to the management and treatment of rare disorders, because we would get sporadic requests throughout the region and couldn't expect one hospital to pay for this. One example would be the regional apheresis service that the Yorkshire Centre provided, but there were other specialist services like tissue typing and HLA typing that remained centrally funded. Cross-accounting is simply a mechanism whereby we were prohibited from making a profit from the service we provided. As far as donors and health service users are concerned, blood is free. There was some difficulty in us getting the message across that there was a cost element to the obtaining, testing, processing and distribution of blood. The importance of the cross-charging question was that Dr. Robinson noted in her statement at paragraph 34 that in relation to BPL paying for plasma and BPL selling their fractionated products, the price for a unit of apheresis plasma, she says, proved to be insufficient to cover the cost of producing it at the Yorkshire Centre. And the question of costs is something that crops up in a number of the documents that we will be looking at today. In 1986, there is a series of letters and discussions between the Regional Health Authority and Dr. Tovey, which may provide some insight into the relationship between the centre and the Regional Health Authority. If we could turn to NHBT 301079, please. And if we could pick it up at page 3, just to give a context to what we then look at. This is a letter from Dr. Derek Tovey to Dr. Smithies at the DHSS. And he says this: "My responsibilities as director have always been somewhat vague here in Leeds. My predecessor was labelled Regional Blood Transfusion Officer. When I was invited to take over after his death, I consulted other blood transfusion directors and the DHSS advisor on blood transfusion, and everyone advised me not to accept the post unless I was appointed director. The Regional Health Authority somewhat reluctantly agreed. To be fair to them, they have always been helpful to me, and I cannot recall a time when they have not consulted me regarding any major decision necessary for the Regional Transfusion Centre. However, a couple of years ago, I discovered that I was responsible to the Regional Medical Officer, the Administrator responsible to the Regional Administrator, and the Head Nurse responsible to the Regional Nursing Officer. Even the RHA realised this was ludicrous. We finally agreed on a compromise. We formed a board of management consisting of the head nurse, administrator, senior chief technician, with myself permanently in the chair, and this has worked quite well. A year or so ago, the RHA appointed Pricewaterhouse to study the administration of the RHA, and as the BTS was under the direct supervision of the RHA, we were included. Pricewaterhouse visited us for 1.5 days, and the final report accepted by the RHA contained one section on the BTC. As you'll see, it suggested the appointment of a general manager. No mention of the place of the director. I immediately asked to see the newly appointed regional general manager and regional medical officer. I was informed that the new organisation would put the BTC under the care of the regional supplies officer, who was responsible to the regional personnel officer, who was responsible presumably to the regional general manager and the RHA. I immediately protested and enclosed a copy of a letter I sent to the general manager. Frankly, he was astounded by the range of my duties and responsibilities. I then suggested that my job description and presumably my contract should reflect both my director role and my managerial role, and the RHA, after consultation with me, has drawn up the enclosed proposed job description. If we then turn on to page 10, please, Sully. We can see the letter referred to that Dr. Derek Tovey wrote to the Regional General Manager of the Yorkshire Health Authority. It's dated the 13th of February 1986. And we see a modern transfusion centre has many functions, and then a series of headings: the collection of blood, blood testing, the preparation of blood components, the issue of blood and blood products to hospitals in the region, and this is worth picking up the detail, in order to ensure adequate stocks are available and that they are suitable and safe for transfusion. There is a need for direct clinical contact with hospital haematologists and other clinicians, e.g. cardiac surgeons. This necessitates a need for direct access to the clinical services. We cannot function efficiently if this clinical need is not carefully monitored, e.g. an additional cardiac surgeon, say in Hull, has major implications for us. There is a growing demand in the hospital service for expertise in transfusion medicine, i.e. expert advice, not only in the collection and preparation of blood and blood products, but also their administration. And if we turn over the page, we then see the remaining headings of the functions, as Dr. Derek Tovey saw them, of the modern transfusion centre. 5, the investigation of blood transfusion problems in regional hospitals, antenatal testing, plasma exchange, tissue typing, and then other associations with clinical and GP services, donors or antenatal patients with positive serological tests, e.g. syphilis, hepatitis B and HTLV3, need careful medical assessment and direct contact with the consultant or GP, and then a series of other functions. And then at the bottom of this page, please. Dr. Derek Tovey says this: "It's obvious, therefore, that what one may label the supplies aspect of the blood transfusion centre is only one segment of our activities and responsibilities. I maintain we have a major regional clinical role and therefore merit a much more direct access to the regional health authority than is at present envisaged, namely BTS to supplies manager to personnel manager to regional manager to the regional health authority." And over the page. There is a continuing need to have access to both senior medical and administrative staff at region. Decisions of major importance to patients and donors, e.g. aides, have to be taken quickly after consultation at a senior level, and the proposed structure would, in my opinion, prevent this. Up to the present, I have had a necessary direct access to senior medical, nursing and administrative staff at the Regional Health Authority, and if this was replaced by a more circuitous consultative machinery, not only would the blood transfusion service suffer, but also patient and donor care. So they were the concerns that Dr. Derek Tovey raised when the reorganisation was proposed. And if we turn back now to page 6, we can see the job description after those discussions. And we see that his job title was to be BTS Director / General Manager, and the managerial accountability was described in this way: the Director General Manager is managerially accountable to the District Services Manager, but has a strong professional accountability to the Regional Medical Officer, who will be involved in professional issues relating to donor or patient medical care. And as far as the inquiry has been able to establish, that is the position that was then followed thereafter in terms of the interrelationship between the centre and the health authority, and particularly the director's role. Moving on then, sir, to the question of self-sufficiency. As a member of the Working Party to advise on plasma supplies for self-sufficiency in blood products, Dr. Robinson was co-author of the preliminary report in June 1981, which set a national target of 100 million units of factor VIII concentrates as a reasonable estimate of clinical requirements in England and Wales by the mid-1980s. A supplement to that report was then presented to the Advisory Committee of the MBTS in a meeting on the 28th of September 1981. And the report concluded that manual pheresis was the most economical way to meet the required plasma volumes. But Dr. Robinson was unhappy with that recommendation, and we can see a letter that she then wrote to Dr. Gunson. Could we have DHSC 302211_072, please? In the middle of the page, she sets out her main concern. My main concern is the emphasis on manual plasmapheresis as the most economical way of achieving the required plasma volume for the following reasons. There is no code of practice regarding the running of 8-bedded plasmapheresis units, i.e. staffing levels to ensure safety, the number of centrifuges required to ensure speed and safety. Such considerations could lead to higher equipment costs and staffing revenue. There has been no trial in this country of large manual plasmapheresis units, and it's debatable if the donation time of 1 hour can be achieved safely with the staffing levels recommended in this document. The plasma volume may well be achieved, but the only study so far done on factor VIII yields from manually collected plasma is by Jim Smith at Oxford, and the results were poor, i.e., one must not think in terms of kgm of plasma obtainable, but of factor VIII yields per kgm of plasma achieved. To date, plasma collected by automated plasmapheresis has higher yields per kgm of plasma than plasma collected by any other method, i.e., a smaller volume of automated plasma is required compared to manual plasma. In conclusion, I feel that until a properly conducted trial of manual plasmapheresis has been carried out in this country to establish equipment necessary, safety precautions, if we can continue down, staffing levels, factor VIII yields, then over the page, manual plasmapheresis cannot safely be recommended as the most economic means of plasma collection. And then the final 2 paragraphs of the letter. I have been given the go-ahead for a 6-bedded automated plasmapheresis unit in Bradford. I shall liaise closely with Jim Smith to establish the factor VIII yields achieved by this means of collection. It's important that a trial manual unit is set up as soon as possible so that direct comparisons can be made about the economic viability of such units. We then have Dr. Gunson's response at DHSC 302211_071, please. It's dated October 1981, and if we pick up the middle paragraph, please. He refers to the supplement. This was, of course, a supplement to the preliminary report and has to be taken in conjunction with the main report, where the point was made very forcibly that it was important to carry out a trial of manual pheresis. I agree it's essential that a code of practice will have to be established and staffing levels will have to be considered. I am pleased that you have got permission for your automated pheresis unit, since this will be the first one of its type in the country dealing with normal donors, and the code of practice which has been set up for such units was based on much smaller numbers. There is a school of thought, to which I don't necessarily subscribe at the moment, that there ought to be 1 trained nurse per machine in such units, and it will be very interesting to see how you get on with your 6-bedded unit. So it appears that as at October 1981, the unit of an automated pheresis unit in Bradford was the first of its type in the country.
It says the first of its type dealing with normal donors.
Dealing with normal donors, apologies.
So there may be others presumably dealing with a small cohort of dedicated plasma donors.
Exactly, apologies, sir, yes. The first of its type dealing with normal donors.
So this is, I suppose, regular donors or people who come in off the street.
It appears that way.
And are then offered plasmapheresis.
And automated plasmapheresis.
Yes.
Yes, sir. In terms of the setting of regional targets at the Yorkshire Centre, Dr. Robinson set out in her statement how the regional targets were set. The target was based on the factor VIII required nationally and then apportioned between the different regions. Therefore, our target didn't necessarily equate to the demands of our local population. And Dr. Flanagan, in his statement, describes the process for setting targets for supply of plasma to BPL in this way. Essentially, the price for plasma was set by the CBLA and the National Director of the NBTS and approved by the NBTS Steering Committee. National plasma volumes were developed by the CBLA, and individual RBTSs then made a bid for the volume of plasma they aimed to supply. Volumes were agreed. If we can then pick up it in relation to targets. DHSC 302267_039, please. We have here a letter from Dr. Derek Tovey to the DHSS dated the 19th of April 1985. Prior to this letter, an administrator had completed a form dealing with plasma procurement, and the letter from Dr. Derek Tovey here accepts that the administrator indicated that there was no detailed consideration about how a target in 87-88 would be met. He says this: although we aim to achieve the target of 31,500, there is a gap. This gap, apologies, sir, I should have taken you to a document just prior to that. That's my fault. I misread my notes. Could I just go back a document? DHSC 302267_011. Apologies, I couldn't read my handwriting, sir. This will make much more sense. This is the letter from an administrator for Dr. Derek Tovey, dated the 9th of April 1985. And if we turn the page, we can see a table setting out the quantity of fresh frozen plasma to be supplied to the BPL from Leeds. April 1985 / March 1986, we have a total of 17,100 as against a target of 17,000. April 1986 to March 1987, we have a total 26,100 with a target of 26,000. And then April 87 to March 88, we have a total of 26,100 against a target of 31,500. And it's in relation to this gap between the total that they will be able to supply and the target that the region's been given that the letter from Dr. Tovey addresses. So if we can go back to that letter now, DHSC 302267_039. Middle paragraph of his letter, Dr. Derek Tovey says this: although we aim to achieve the target of 31,500, there is a gap. This gap can either be bridged by increasing the SAG-M collection, but until we have had more experience of this, we do not know if the clinicians will accept a higher percentage. The alternative is to open a third machine plasmapheresis centre. The point I'm making is that we do intend to reach the target. It's simply that we haven't decided at the present time which of the alternatives we'll put into operation. So we can see from the prior table that broadly Yorkshire could meet their targets, but in that particular year there was a query over exactly how they would meet that target. In fact, when we come to 1989, we have a letter from Dr. Robinson dated the 22nd of March 1989 informing Dr. Gunson that the Yorkshire Centre had not met its plasma target. If we can go to that letter, please. NHBT 0027512. Dr. Robinson indicates that they'd finished planning their strategy for achieving their plasma targets for the next few years, and she provides him with the overall plan. If we can go down, please. 1988-89, volume achieved 24,607 litres, target was 26,000 litres, and the shortfall is put down to industrial dispute over clinical grading, increased local use of cryo and FFP, and a loss of 10,000 donations. And for 1989-1990, the target is 27,000 litres, and the proposal is to increase SAG-M donations and to extend Bradford by 18.75 hours per week. Adequate number of donors already recruited. Given the necessary staff recruitment, expansion can take place immediately. If we turn the page, we see a note on the targets and the objectives, and then this action plan. Action plan necessary to achieve these targets: extending the hours of the Bradford Centre by 18.75 hours by immediate staff recruitment and training, recruiting 4,500 more plasma donors for the St Paul's Street Centre and the new donor suite at headquarters over a 3-year period. Both at present are working under capacity because of the insufficient donor recruitment. Increasing the number of SAG-M donations to provide an extra 4,000 litres per annum, and improving ordinary whole blood donor recruitment and retention such that the 10,000 donations lost in the last 2 years are regained and maintained. We'll pick up that issue of loss of donors shortly. Dr. Gunson then visited the Regional Transfusion Centre in or around August 1989, and it was agreed that the 1989-1990 target would be revised. We can see in a document relating to a CBLA-NBTS liaison meeting that costs were also an issue. Dr. Robinson stated that the plasma supplied by the Yorkshire Centre was costing £15 per kilogramme more than the income received from it. Just for the transcript, the reference is NHBT 5077_056. It's not entirely clear in that document whether Dr. Robinson was referring to recovered or apheresis plasma, but Dr. Flanagan comments on this in his statement and says that there was a significant concern to the Yorkshire Centre because the deficit in cost recovery for the plasma will have been added to the price charged for local components issued to hospitals in the region. And consequently, these charges will have appeared higher than those set by other RTCs who were providing less plasma to BPL. So there was an impact across the board. If we then pick up the situation in August 1991, in a letter dated the 13th of August, if we could turn to that, NHBT 00169094, please. It's the second page. Having set out matters of the plasma being supplied, Dr. Robinson said this to Dr. Gunson: "What I can say is that the current uptake of BPL factor VIII products by the Yorkshire region indicates a likely annual usage of 8 million units. Our 1991-92 normal plasma input is targeted to be 37,000 litres, 24,000 litres recovered, 13,000 litres apheresed. Assuming the factor VIII yield is approximately 190 IULs, the YBTS supply of source plasma to reach regional self-sufficiency in terms of the BPL factor VIII uptake by the Yorkshire region is equivalent to 42,000 litres. I'm back to my original theme of linking plasma supply to BPL by RTCs to the regional uptake of BPL products, i.e. if I'm going to purchase 8 million units of factor 8 for regional distribution, I would like the opportunity to supply the volume of source material required to produce 8 million units of factor 8. So by 1991, there is a concern being raised by Dr. Robinson that Yorkshire want to supply or have the opportunity to supply the volume of source material that is equivalent to what the region then distributes to the relevant centres.
Is she saying there that she'd like to supply more in order to get enough? Or is she saying, I'd like to supply just what is needed? Because they're two different things. Is she complaining, perhaps, if the latter be so, that Yorkshire has been asked to do more than its weight?
That hadn't been my reading, sir, but it could certainly be a reading of the letter. The last paragraph of the letter might suggest otherwise. If the target of 37,000 litres from the Yorkshire region is likely to be in excess of our allocated BPL quota, please could you let me know?
Yes, but the question, who sets the target?
Indeed.
And I thought the target was being set by BPL, in the earlier documents, and it was up to Yorkshire to see if they could achieve it.
Yes, so it could be read that way, sir.
So it's, and the overall picture across the country that's been painted so far is this, is it? That regions are set targets by BPL looking at the region and saying, you've got so many people in this region, this is your fair share of our needs. That may be all very well, but some of the regions have a much higher usage than others. And so if they get back pro rata, they don't get back enough.
Indeed.
Others are supplying more than they need, and that comes at a cost to them, and they complain that the cost which is attributed to them by cross-charging is actually less than the cost that they have, and so they have to charge more for other products supplied locally.
Indeed, and as you say, sir, that ties in much more clearly with the concerns about costs and the concerns about cross-charging.
And it would fit in with the concerns which have been expressed elsewhere in the documents you've referred to, where there's a concern that Yorkshire's supplies to its hospitals may be compared by clinicians, in effect saying, well, you're charging us, I'm just picking figures at random for the point, £5 for this, but down in this other region they only charge £4.
Indeed, so that interpretation of this letter would certainly fit with those other documents. But it's not entirely clear.
It's not. Well, the wording would suggest you're right in the first place, but the context is the opposite, perhaps.
Indeed. Yes. I think perhaps, let me just go back. Apologies, sir. No. Either way, sir, it is clear from many of the documents that Dr. Robinson was an advocate of plasmapheresis, and indeed in her statement she said this: I became a national and internationally recognised expert in both donor and therapeutic apheresis and introduced the first voluntary donor automated plasmapheresis centre in the world in Bradford in 1982, which is what we looked at earlier. Dr. Robinson wrote up the pilot plasmapheresis programme in Yorkshire in an article she co-authored with others, including Dr. Tovey, for Vox Sanguinis. It's DHSC 302263_064, please. And if we just look at the abstract, we can see that there was a pilot study for large-scale automated plasmapheresis using a particular machine that was undertaken in the Yorkshire region of the UK to determine the viability of such a programme for national self-sufficiency in fresh plasma procurement for factor VIII concentrate production. The study was designed to resolve 3 areas of concern: donor safety and recruitment, a cost analysis, and the choice of anticoagulant for optimum factor VIII yields. The results show that large-scale automated plasmapheresis could safely and economically produce high-quality source plasma necessary for national self-sufficiency. And that was published in 1983. As a member of the UK Blood Transfusion Service Apheresis Working Party, on behalf of the UK BTS NIBC Standing Committee for Blood Donors, Dr. Robinson was also responsible for co-authoring the guidelines prepared by that working party, including guidelines for apheresis of volunteer donors within the UK Blood Transfusion Service. In moving on then to donors and selection of donors, Dr. Robinson's personal statement made it clear that blood donation was not by appointment, so mobile teams had to make their presence known in an area in order to secure donors. The Yorkshire Centre produced a lot of its own publicity material, and when the centre was short of donors, Dr. Robinson might put out a radio appeal for more to come forward. If we could turn to NHBT 0033679, please. We see a letter from Dr. Robinson to Dr. Gunson addressing a campaign that the Yorkshire Centre mounted in January 1990 to reassure donors and non-donors that there was no risk of infection when giving blood. This had followed a sharp decline in donor attendance. And what is useful to see is the bottom of the page, their plan of action, just to give a flavour of what the centre was doing. Posters and leaflets are being distributed for public display to the 7 district family practitioner committees within the Yorkshire region for display in all GP surgeries, all health centres, community clinics, libraries, citizens' advice bureaus, etc. And she enclosed a copy of the poster and the leaflet. Then over the page, a large simplified poster on similar lines as those enclosed to appear for a period of 3 months on the backs of buses, 100 in all, travelling within the Yorkshire region, at all railway stations within the Yorkshire region. To follow up, informational display stands and a video are being prepared and will be coming online towards the end of March, and a press release by the Yorkshire region in association with the PRO agency would be prepared. So they were some of the measures that Dr. Robinson took in order to increase donor numbers. Dr. Robinson, in her statement, recalled attending a session at Wakefield Prison when she was a senior registrar. So that must have been prior to 1976 when she became a consultant. She didn't recall any prison collections after 1976 once she was a consultant. She further recalled that when the Plasmapheresis Centre in Bradford was opened, the Yorkshire Centre didn't allow donors with a prison history to donate because of the association of institutionalisation, increasing the incidence of hepatitis B and non-A, non-B hepatitis. So she, in her statement, thought that the centre was not collecting blood from prisons by 1982. However, a separate document, so which the inquiry has seen on a number of occasions, NHBT 308628_001. It's the Scottish Transfusion Directors Survey from 1983. If we just turn the page, we see this in relation to Leeds. Dr. Derek Tovey is different. The region has large prisons at Wakefield, Leeds and Hull. They tried to withdraw prison sessions and got a very active response from the prisons, which asked that the session should continue. The session staff get help from prison staff to exclude volunteers who are medically unsuitable. Dr. Tovey received a letter from a prisoner seeking reassurance that if an abnormal result was obtained on donation testing, the prison donor would be informed. The prisoner considered this to be a valuable service performed by BTS. So Dr. Robinson's recollection was somewhat at odds with what we have here in 1983. In terms of the selection of donors, there are various examples in the documentation seen by the inquiry of Dr. Tovey corresponding with donors about whether or not they should be excluded, for example, where they've tested positive for hepatitis.
Just pausing for a moment. Looking at the commentary there, which is written about Leeds, the last of the 3 paragraphs on the screen. The reassurance which the prisoner wished was that he'd be told if there's an abnormal result. And then there's this comment: the prisoner considered this to be a valuable service performed by BTS. One implication of that might be that a prisoner or prisoners thought that it was useful to give blood because you could be tested. In other words, they thought they might be suffering from something, and they'd find out.
Indeed, that might well be one interpretation of the situation.
Which it might be thought to be part of the reason you didn't want to have collections in prison, but...
Indeed.
This is all comment and subject, of course, to being shown what it really means later.
Indeed.
Thank you.
In the documentation, there is various examples of Dr. Tovey's actions of letters to donors who tested positive for hepatitis. We can then pick it up more clearly in June 1990, when the Yorkshire Centre published a document entitled Criteria for the Selection of Whole Blood and Apheresis Donors, NHBT 0033676. And third page, please. We see at points 4, 5 and 6, only persons in good health should be accepted as donors of blood for therapeutic use. The ultimate responsibility for the selection of donors rests with the RTD. The immediate responsibility is that of the medical officer or nurse in charge of the session, who should evaluate the prospective donor's medical history. If there's doubt about the suitability of a prospective donor, a donation should not be taken and details should be referred to the RTC for a decision. Then over the page, the second paragraph, a significant part of the assessment procedure will usually rely on answers to questions relating to general health, past medical history and medication. This is combined with simple visual assessment of the donor and selected testing of samples collected at the time of donation. There's then the reference to a set of questions, a standard set of questions that are to be asked, which we'll look at just in a moment. And then this at the last paragraph, inspection of the donor. The donor should appear to be in good health, and various other positions are noted. This procedure used skillfully will lead to rejection or suspension of most donors who are unfit to be bled, and it should be carried out meticulously. And that's the suggestion of looking at a donor for poor physique, debilitation, undernutrition, or the suggestion of intoxication either by alcohol or narcotic drugs. In terms of the questions to be asked, If we turn to page 7, we see that it's the heading specific questions. All donors should be specifically questioned about the conditions listed on NBTS 110A, and every donor should sign NBTS 110. They're documents that the inquiry has looked at a number of times. Each prospective donor should be asked a standard set of questions prior to each donation by a donor attendant. Any condition declared should be discussed with the medical officer or nurse in charge. And we can see those questions at page 33 of the document. We see a set of questions of feeling well, coughs and colds, and then at Roman 10, have you read the AIDS leaflet? So it might appear that the leaflet was given to donors and they were required to sign confirmation, but in terms of verbal questioning, it was limited to asking whether they had read the AIDS leaflet. So I'm about to move on to a slightly different topic. I don't know whether it would be appropriate to just take a 10-minute break before we continue.
Well, let's make it a quarter of an hour, shall we?
Of course.
And come back at 20 past.
Thank you.
So 20 past 11.